the folks that I support, I'm having trouble getting around it because so many people are working so hard to get some progress and to do better.
Yep.
And I don't. I'm just trying to narrate in my head how I'm going to deal with those conversations when they say, "Well, there's no point. I wasn't even getting close to the 2 drinks a day. I'm never going to get to 2 drinks a week. So what's the point?" We're going to talk today about alcohol
use,
and not necessarily people that have an alcohol use disorder, but I think most of the people that we see in the context of our work that drink alcohol probably do have an alcohol use disorder.
Absolutely, they probably do. And for alcohol use, it's an interesting thing because it's only been a couple of decades that the healthcare profession has been assessing and treating it. Usually the healthcare profession will see you for the medical comorbidities you have. Maybe you have some liver trouble, some hypertension, maybe you have diabetes out of control because you're drinking. And you'll tell them, hey, stop drinking. But now, more so in the last decade, the last 2 decades, 2-3 decades, we're using medications. A lot of physicians are trained in motivational interviewing, and they try to really get people to make those behavior changes, as opposed to like, hey, the drinking is going to kill you.
So this is the is this alcohol and the connection of addiction medicine? Did they come together at a similar time?
Yeah, I think it was the opiates that came first, but I'm not sure. All I know is that the whole reason AA developed and the do they call it a brotherhood?
I think they do. Well, I think they do. Maybe they've changed that speaking of language to the sisterhood.
Yeah, the language, but it historically
fellowship. I think is that.
Fellowship. There we go. Thank you. Yeah, the fellowship. It's people who were drinking or who used to drink that were helping people who wanted to cut back.
Yes.
And it was not the healthcare profession. And in fact, there was a lot of judgment. It was really seen as a personal failure, moral failure. And it's only been lately, and now they have that whole field, addiction medicine, that does that. And
So, so you see the addiction medicine is sort of newer than AA because AA has been around for a lot.
Absolutely, I know it's a lot newer than AA, and it's got a lot more traction lately as well. I mean, when I even like a decade ago when I did the fellowship, there was maybe like 8 spots in the country that people were doing that. Kind of extra training for addiction medicine, addiction psychiatry. Now there's definitely more. And there was an organization in the States for 20-30 years that was training people, but it's only really gotten like an official medical subspecialty in the last 5-10 years or so in the States and here.
Okay, and in the news this week we have the I'm gonna butcher their name, the Canadian.
Yeah, the Canadian Centre of Substance Use, CCSA.
Okay,
they're a really great organization, and our colleague, Alex Cotterella, is the CEO there now.
Yes.
This project was actually done earlier, and Peter Budd, whom we had dinner with in Saskatchewan, is one of the key authors on there. And it was fascinating just to hear about the process. I mean, it was one of those things where they got some real, I don't know if the word you can use is hardcore, but they got some real scientists to really dive deep in the data. And what they found, most people who do alcohol research wasn't new, but the way they framed it, right? Because they were really looking at risk. So what's the change in risk to healthcare? And they're also looking at the risks that relate to behavior too, right? So the risks around like violence and driving and all that kind of stuff, for it.
Yeah. So so just generally, if we could sort of summarize, this is a lot of it was focused on cancers, I think. So and the risk of getting of cancer, and I think they put it from for men it was we were at 2 to 3 drinks a day, standard drinks a day was the previous recommended safe use. That would
so the terminology they used before was like at risk for unhealthy drinking, right? That was the way they framed it.
Okay.
So they didn't say it was like an addiction, right? And so
no, this is different from a substance use. This is not a criteria for whether or not someone's
exactly.
use disorder.
Yeah, it's just like if you're drinking more than the recommendations before, you were at risk for developing a substance use disorder. Whereas this one, it's the risk around cancers and stuff like that. And before, I think it was 15 drinks a week for men and 10 drinks a week for women, and then I think it was like 2 or 3 in one sitting, depending on your gender.
And but now it's gone to 2 drinks a week.
And that's if you want to drink at a level that doesn't significantly increase your risk of certain kinds of cancer.
If you don't want to shorten your life, it's basically the way that.
Well, the challenge is that like some of the cancers, the risks of developing it are so low, right?
Mm-hmm.
Like it's like 0.2, 0.02, whatever it might be. And even if you double that risk, right? Like maybe it's a risk somebody's willing to take. And so I think we would just want to be very clear, around the guideline versus I think awareness of risk. And I would really frame it more like cigarettes than I would frame it as like risk around addiction, where like obviously people say cigarettes are all bad, but there's different kinds of risks that occur with different levels of smoking, and there's different levels of risks that occur with different levels of drinking.
Sure. It wasn't that long ago that there was I'm sure there's many people that still have the common misbelief that a glass of wine every day is an okay thing. In fact, it could help you. That's what there's a lot of.
Yeah, and it gets more complicated when you dive deeper into the literature, right? And this is where it's almost better to have a real scientist as opposed to me sort of come on, because it all depends on how you look at the data and at what levels and what the actual benefit and what the actual risk is. From what I understand, it was correlational data from Europe that suggested people that were having that 1 glass of wine a day had less risk of heart disease. But when they've looked at it several different ways, the benefits aren't so clear. And it might not even be the alcohol component. It might be something else that was in the wine that was doing it, right? So I thought
that was settled science, that it wasn't. That isn't 1 drink a day is not good for you.
Yeah, it is.
Okay,
yeah.
All right.
Yeah, but I don't want to say anything wrong, right? Like I haven't reviewed the literature lately, and then there's so many different spins people take on the same data.
Sure. Okay.
If that makes sense.
Yeah. No, and I was reading about this physician. I'm sorry for getting his name, but you've probably known him. He's from Saskatchewan. Who he was a physician and now he's a distiller.
No, I don't know.
His liquor company is called Lucky Bastard. And you know why it's called Lucky Bastard?
No, I don't know why.
Because while he was a phishician, his first year being a physician, he he was doing a locum or something, and then he went and bought a lottery ticket, and he got $14.3 million in the lottery, and then he decided to quit being a physician and get into the distilling business. But and they interviewed him about what. How he felt about these new guidelines as a distiller. There's some conflicted interest as a former physician, and and he, it's I'm not going to paraphrase what he said, but I think he's a little bit more nuanced about it, and everything is risk, as we know, right? So, but I just think it's interesting. I know for the folks that I support, I'm having trouble getting around it because. So many people are working so hard to get some progress and to do better. Yep. And I don't. I'm just trying to narrate in my head how I'm going to deal with those conversations when they say, "Oh shit, well, there's no point. I wasn't even getting close to the 2 drinks a day. I'm never going to get to 2 drinks a week. So what's the point?"
Yeah. So this is where I think there's good data out there, right? Both in terms of the guidelines and. We'll put a link to the picture of it, right? But there's also these World Health Organization levels of drinking as well, and the levels are very different, right? I think it's like 0 to 2 per day, then it's like 2 to 5, and then like 6 to 9 and stuff like that. So, but each level you drop, there's significant health benefits to it. Right. And so say if you're working with somebody who's had 15 drinks a day and they drop down to 9 drinks a day, there's significant health benefits. You 100%. Drop from 9 down to 6. There's like these aren't like these are big differences, right?
Yeah.
And I think it's all about framing. I mean, you've seen me sometimes when I come in here, I'm a little bit of a downer sometimes, right? And part of it is that sometimes the lens that I'm focusing on is just the glass half empty kind of thing. But I'm telling you, like, deep hidden within that data is that they, with especially with that color scheme that they have, you can see the impact of dropping down from 20 per week to 10 per week to 5 per week to 2 per week, and it's different risks of dangerous things that goes down. So it's really not much. And and the other thing you could always do is you could always go back to the old school guidelines. Like, look, they have this new ones out here for now, but let's, like, I think it's really what you've always brought up with me about meeting people where they're at.
Yes.
And then figuring out that the harm, and we definitely don't want to
discourage people.
Yeah, discourage. Well, we don't want to make that it's like all or none. Either you had 2 drinks per week and you're fine, or you're more than
or
not,
have 2 bottles a
like
day now.
there's a lot in Eastern philosophy and also in other places about falling in love with the process, falling in love with the grind, right, as opposed to the outcome. I mean, you do need to pick some kind of a target, but it's the process that really allows the people to thrive and continue to do so.
Yes. Okay, so that's where that's at, and that's I guess that's one organization. I understand Health Canada is still going to review that work, and that isn't the settled policy for the country yet, because it's Health Canada.
Well, who knows what the settled policy for the country is. I mean, Health Canada has a history of not necessarily doing a deep dive into the science before it recommends things or approves things, right?
That's true.
And so in terms of, like, for example, the cannabis medicalization of cannabis, that was done without any healthcare body involved in it. And so I think, like, in terms of scientifically sound, I think you can't do better than what the CCSA did, especially with their tables of how it stratifies risk. And I think other places are going to follow suit, right? And I just hope that they shift the language about awareness of what the actual risk is, as opposed to this is a guideline. I mean, there's this one I guess it became a meme, but there's one guy who was talking about 2 drinks a week. That's not enough to get me through the day, right? Like, there's this video, it's like 30 seconds long, and the guy's so, like, authentic and real and passionate, and he's just speaking what a lot of people are thinking.
I think I saw that, and I think someone said, "I want to buy that man a beer," right? Or something.
Yeah, well, I mean, like, you need people like that in the world who are truth tellers, right?
Yes,
that'll just
100%.
And it wouldn't have gotten so viral if it didn't resonate with so many people, right? So
right, okay. So, and again, this is not a speaking of percentages, I think I heard one kind of scientist put it out there and saying, well, what if you drink one drink a day for the rest of your life, right? And he said, well, it's something like a 1% increase in a cancer risk if you're at that level.
Yeah, so and that's what I mean. That's why you got to go to the table. You got to go to the table, see what it says, and then you have to decide what's right for you. I mean, some people love smoking cigars. Some people love whatever with all those risks.
I suspect living in Toronto with the air quality that it is, I'm sure that we're kind of impacting ourselves in a negative way as opposed to living out in Saskatoon or something. So
or even like 2 hours out of Toronto. It's absolutely true. I mean, they've done studies even in terms of like kids' breathing health. The closer you live to the Gardner, and it's startling.
Asthma rates and all that kind of stuff.
Yeah, that's exactly it. Yeah.
Okay, so that kind of covers where we're at on the safe drinking guidelines. Is there anything else you want to say about that?
Yeah, people don't get discouraged. They just see it as like, hey, you know what? We're being more transparent around what the actual risks are, and you get to decide what's important to you and what you want and what you're looking for.
Less is better, but it's just more knowledge, really, right? Like,
and I mean, there's no alcohol that's like safe for you. At the same time, it's your choice if you want to do it, and it's something where if you want to help, either cutting back like a level, right? So like whether it's like to the red, to the yellow, to the green in their cartoon drawing, whether it's just moving towards or getting to that 2 goal, there's a lot of good places to get help for it. Maybe radiation oncologist, I don't know.
There you go.
Is that what it was?
That's what it was. Yeah. So they had him on there and they said, well, I've been doing this for 20 years.
And what did he say?
I'm about to tell you. He said.
No, but what did he say?
He said, I've never given someone a smoker the news that they have cancer and they're surprised about the connection to smoking. Right? I've never once in 20 years. But he said you'd be shocked at how many people are surprised. In fact, he says the majority seem to be surprised that there's a connection to alcohol and cancer.
It's a very strong connection. It's unbelievably strong.
So if nothing else, perhaps this is getting that message out there a little bit. And again, it's not to scare people. It's it's just to get more knowledge out there, and so they know the risks. I suspect most of the people we support know the risks already, and they.
Yeah, no, I don't think they know all the cancer risks, because I was surprised too. I was surprised when I saw the cancer risk. I was surprised when I saw the the blood pressure risk, and I was impressed how they quantified some of the behavioral risks. Right, like if you go out and drink heavily and black out, you might be at risk of something dangerous happening, or you doing something dangerous, right? And so I was impressed with how they actually quantified those risks. And I hope as a society we continue to do that.
Yes.
Like, and as opposed to framing these things like guidelines, really framing these are what the risks are.
Yeah. Spread the knowledge out there. It doesn't have to be a secret. Let's let everyone know what the challenges are, and that's a win.
Whatever is important to them, that's something that can be worked on. I mean, can you imagine what's going to happen if you start doing this for like sugar or for carbs? That's going to be nuts, eh? Because the amount of like lobbies and large companies and the income. I mean, like I was shocked when. I started reading about the basics around Coke and things like that, and then I was shocked that like even with those Diet Cokes and the other ones, your pancreas responds like it's regular sugar, and I was shocked at like how abdominal obesity has gone through the roof in North America, and I mean, can you imagine if they use the same risk scales for that? They wouldn't be able to publish it. They would get sued. They would get death threats, probably the scientists that were doing it. It'd be like, what was that movie, Thank You for Smoking? Like, how long did it take, like 30, 40 years before, like, you could say that cigarettes cause cancer? You couldn't say it for 30, 40 years, right? Because it's like, no, it's correlated, right? So,
Not to quote Donald Trump, but his quote is, and he's an avid Diet Coke drinker, I think they say. He says, I don't know anyone that isn't fat like me that drinks Diet Coke.
Okay, I get it. I was like, is this safe to laugh to, or was it a racist statement, or can I laugh to it? Right? Well, I guess you can laugh it because he's making fun of himself.
Yes, he is.
He says he drinks Diet Coke. He's saying he's fat, and everyone he's seen who drinks Diet Coke is also fat.
Yes.
Yeah. Although my wife drinks Diet Coke.
All right. Well,
she's not.
She definitely is not fat.
No, she's definitely not.
We have disproven the theory.
He's a liar. He's a liar.
Yes.
He's a liar. Okay. Yeah. Please do not bring his quotes up again. I'm just joking.
Okay.
All right.
So, alcohol. What more do we want to talk about?
So with alcohol, I think as a healthcare provider, I think your approach is really going to depend on whether or not you are there to see a person for the alcohol, like we are at our jobs, or if you're seeing them for something else. And if you're seeing them for something else, you probably want a screening question or two. Mm-hmm. At first, screening question, what you'd want to ask, although it might have changed now with these new guidelines. The best screening question for unhealthy drinking was, in the last year, have you had 5 or more drinks in one sitting for men, or 4 more drinks in one sitting for women? If they say yes, then it's reasonable to do alcohol history.
Right. So that's the SBIRT.
Is that what it is?
Short, brief intervention
and referral to treatment.
Yeah.
I mean,
but I wonder that's a good question. Does the SBIRT change because of this new? It'll be interesting.
Well, it's tough because they've studied it so much, right? And I don't even know if that was a question on the SBIRT or not. So it's because the SBIRT's its own sort of screening tool. I don't know what questions they have on that.
Yes, as I recall, it is
one of the
many drinks that you have.
Yeah. So there's that. There's the CAGE. They used to ask the CAGE a lot, but it doesn't have as good specificity or sensitivity.
And what's that an acronym?
CAGE is for like, have you had difficulty cutting down on your drinking? Have you been annoyed at others when they talk about your drinking? Do you feel guilty the next day after drinking the night before? And do you have to have an eye opener in the morning? And so that was the standard for questions. And if you scored, I think 2 or more for men or 1 or more for women, it was signaled to do more further assessment.
That's getting closer to the kind of
the SBIRT?
Closer to an alcohol use disorder
Yeah,
diagnosis specifically almost.
Yeah, and then the other one is the audit, right? And the audit is one of the favorite ones that we like in healthcare because it actually gives you a number at the end that helps you with the severity. So the audit is about 10 questions, and we'd have to post because I don't remember them by heart. And if the score is like 6 or 7 or under, not much to do there. If it's between 8 and 15, then the risk is low. But if it's 15 or above, it's highly likely that there's problematic drinking, and then you want to do a bit more of an intervention.
Okay, and we can post that audit in the
absolutely. And there's a 3-question one, and then you can set up so you do the 3-question. If it's positive, then you do the full 10-question one, and it's nice because it also gives you a clue on the severity piece. I mean, there's some limitations, but it's a great screening tool. And then the other screening tool is called the PAWSS. It's called the PAWSS, and it has to do with the alcohol withdrawal scale. It was developed by Maldonado, who's a psychiatrist in California. And it has 2 initial questions followed by about 8 others. And that one is really good at predicting whether or not someone's going to need, 50 milligrams plus of Valium in the withdrawal period.
So these are all the different, we've gone through about 4 or 5 of these screening tools. And these are primarily for what would be sort of a primary care physician.
Yeah, it could be a primary care physician. It could be if you're like doing an intake at a clinic.
Yeah,
you're doing an intake clinic. It could be a community worker. You know, someone's coming to the detox.
Yeah.
You just want to, but say they're coming for opiates. You want to see, is alcohol a problem too?
Yes.
You do a couple of screening tools. And you just have to remember that these screening tools are screening tools. So you still have to do your assessment. And I'm not as good with screening tools as I could be because I just do a alcohol assessment like every time I see somebody.
Yes.
So I think it has to do, it's reflection of where and how I work. So the other thing is with the alcohol, there's very good data on unhealthy drinking, but it's unhealthy based on the old.
There you go.
On the old guidelines. So they do surveys every year in Canada, and that's posted up online. What percentage of people, what age groups, so all that kind of stuff. And then for addiction, I really like the 4 C's. The 4 C's are, do you have cravings to use? Do you have continued use despite negative consequences? Do you find that there's an inability to cut down? And it's almost like this compulsion to keep using. I think those are the 4.
Again, those all sound very much like an assessment for a substance use disorder.
Yeah, they absolutely are. Yeah, okay. And the reason I like the 4 C's, I mean, the DSM stuff is nice too, but the 4 C's, I feel just because in medicine now, prescribing a lot of drugs with addiction potential. Now, we used to do with the opiates, we used to do with the benzos. We're going to start doing with ketamine now and psychedelics and all that stuff. And so I'm a big fan of the 4 C's. And then I just go through the alcohol use disorder questions. The challenge with the alcohol use disorder questions, especially with the way they did in the DSM-5, because it's a spectrum, it's no longer like alcohol abuse versus alcohol dependence. Almost everybody is like positive. You just need 2 or 3, right, to be positive.
Well, I think I don't know about for your own practice, but for my work, I don't think I can't think of the last. There's so many people that see the people I see before I see them that I don't think I've ever been sent somebody to speak with that doesn't have a that's already been
absolutely.
They didn't get in the building if they didn't have one, and then unfortunately they're kind of the most higher needs people are the ones that I tend to see. So they definitely have one, and then it's to the extreme. So, but this is very useful for people that are not in that kind of depth of addiction work, but are seeing people on a casual basis and trying to determine whether or not someone has a use disorder. I know for a lot of others can judge people for a use disorder that doesn't exist sometimes, right? They think any use is problematic. Yeah.
And I find you get really good at the lens that you work in, right? And so we both work in very unique environments. And we've gotten pretty good at doing the job there. But for people who work in different environments, they may not be in a place where they do a full alcohol assessment every time. No. Or they may be in a place where somebody's there for their blood pressure or for housing, and maybe they also drink.
Well, I think one of the real realities that we kind of are missing here is the fact that if they do the assessment, do they have the resources to send them to right? Because we talk about these resources like they're, you know, very open commodities, but they're really not, right? It's really hard to connect with addiction resources.
Yeah. So I think with alcohol, if the person identifies it as being a problem, you do your history and assessment. There's a few things that you try to figure out. One is you try to figure out, does this person need detoxification, which is how to get the alcohol out of their system in a safe way. You think about what they need during the maintenance phase, and what that means is that, you know, either before they've fully detoxed or after they detox, what do they need around that time? And then you also want to think about referral to resources, right? And for the resources, you know, you can think about outpatient, or you can think about inpatient. And in the outpatient ones, you also want to add things like AA and stuff like that. So AA is everywhere. In Ontario, we're pretty lucky. They developed these rapid access addiction medicine clinics 4 or 5 days a week at least, to drop in, where you can get an anti-craving med for alcohol. You know, although the number needed to treat is about 8 for each one, right? And so what do you do with the other 7? And the part that you're talking about, the resources, really has to do with these inpatient programs, or these psychotherapy and counseling options.
Even what you know, you and I take it for granted. We've worked in these clinics for a long time.
Oh, you're saying not everybody knows about it?
Not everybody knows about it.
Oh, yeah, so that's 100% true.
Yeah. Not everyone in the hospital, not even in the hospital that I've worked, where the clinics know about it, right?
When I worked at a tertiary care center, this is like a decade ago, people who were doing mental health didn't know what was offered on the addiction side, and vice versa.
Of course, yeah.
In the same organization, right? So
you don't have to go back 10 years. Unfortunately, I can tell you it's still happening today where they don't. So even when the clinic's literally on the same floor, right? Where the, you know, kind of the mental health is on the same floor. I'm not calling out my mental health colleagues. I'm just saying we haven't done it. We haven't done a good job of if they don't know, it's not because they don't want to know. They don't know because we haven't done a good enough job of teaching them.
That's part of it. But also the other thing is that there's millions of treatments for millions of different things.
Yes.
You're only going to believe in the ones that you've seen work.
True.
So if you have a patient who's gone through something, if you've worked in an environment for a few months and you've seen the impact it has, then you're going to be recommending it to people. There's like, even just like, for example, with medications, there's like, I don't know, 50 meds for depression. I use like 4 or 5 ones regularly.
That you've had success with?
Well, success with, the ones that I used that I was training with, the ones that my supervisors were using when I was there. I don't always go back in time to the ones that were around like 30, 40 years ago. And I'll use logic, like, oh, the side effects or this or that. So we know what we've seen work, and we know. And then the other thing around this, like, because we talked about how in our job we see people in a certain context. We don't work in the emerge all the time, right? We don't work in a primary care practice all the time. We don't work at a ODSP office or a social services office, right? And in those environments, we would see people who drink alcohol where it's a problem, but we'd see a different side of the problem. Right? And so you almost get really, really good at your lens, and you forget about the other lenses and stuff that are there as well. So the detoxification part is incredibly important. And we know this because, I mean, there was that newspaper article that we were thinking of talking about, which we probably should do something separate on. Because if you're drinking more than 8 or 10 standard drinks per day, and like a standard drink would be like a bottle of beer, it'll be like a shot. It'll be like a 6-ounce glass of wine, you know, would be like a drink. And drinking on a daily basis, and you suddenly stop, you're at risk for having shakes, sweats, seizures, and dying. And end of death. And then you have some patients who try to do it on their own. Yes. And they get really sick and end up in a hospital. Sometimes they get really sick and something bad happens. Yes. And other times you have people that are so scared to do it on their own because the doctor says, hey, don't stop. They just keep drinking for 6 months and they just can't stop and cut back. And so for the detoxification phase, there's that screening tool called the PAWSS that you could do to look at the risk. But for me, if someone's drinking daily, they're having more than 6, probably 8 to 10 standard drinks a day, I really want them to track what they're drinking, cut down slowly, see me at least weekly, and then we'll figure a point where we can add some medication to help with the withdrawal process for them.
Right. There's this misconception out there with the folks that we support that addiction, almost all the tools of addiction medicine are displaying some form of weakness to them, right? That they're weak. They can do it on their own, right? So the guy who white knuckles it, as they say, and just quits everything, right, is stronger than the guy who gets addiction care for whatever reason. I mean, that's a ridiculous thing for...
Well, it's not so ridiculous, right? Because it's like, I mean, if so many people think it, Like, yeah, you know,
Well,
I
it's an
mean, it's
unfortunate
ridiculous
thing.
from our end because we're like, nobody's strong enough to fight alcohol withdrawal,
Right.
right? Like you can't stop that seizure from coming just by meditating.
Right. Exactly. And that's why, you know, but it's, you know, what if they believe it, and that's where we're at. So, you know, and a lot of people see these medications as a switching thing, and certainly in the opiate cases, people think of
replacing one drug with another.
Yeah,
Absolutely.
Yeah, and so, you know, if I'm going to quit, I'm going to quit everything. And
yeah, you know, and it comes from a good place, right? It comes from a good place because when you look back at like the 1970s and 1980s, you know, people were drinking a lot. Maybe they go to AA, then they go see their psychiatrist. What does the psychiatrist do? Here's like 2-3 Valium a day, right? Here's 2-3 Rivotril or whatever the names were back then. So I think like these addiction facilities, they could tell, and the pain meds too, right? There was a period that, oh, these are my pain meds, I need them. It's almost like they could see in the people's eyes that, hey, this is like a bit of an addiction. And so it makes sense where that belief came from. But for alcohol or benzodiazepine withdrawal, you need a proper detoxification, and you probably need proper medical detoxification.
Wasn't there something in the whole 12-step fellowship that kind of frowned on medication for a while too? Is there some history to that?
Yeah, I mean, it's been a long time since I've been through the big book. I can't remember. I suspect
there's something.
It might be explicit. It's definitely implicit, at least, right? Where people just know that, you know. And with methadone and buprenorphine, they thought you're replacing one drug with another.
Right.
And with a lot of these addiction treatment places, historically, they've not allowed psychiatric meds for that reason. And I was just trying to explain that it sort of makes sense because sometimes psychiatrists prescribe things in the past that were addictive.
Yes. Yes, but the idea being in a less harmful way, right? So, and anything that's being prescribed, typically, hopefully, is going to be less harmful than what's coming out of the bottle or off the street. That's the hope.
Yeah.
That's the hope.
Yeah, so what does alcohol do in the brain? It works on the GABA receptor. And with the GABA receptor, when it's activated, it slows things down. The brains fire less, you know, you're less anxious, you're less whatever. And then you sort of like flood these receptors. And when you take it away, all of a sudden the cells start firing more. The glutamate starts firing, can fire so much that boom, 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 you get a seizure in some kind of way. And so some places they'll use chlorodiazepoxide. Historically, they used to use barbiturates. But diazepam and lorazepam are the couple of the main ones that they use these days. And over the last 10 years or so, more and more evidence has been coming for gabapentin. And so gabapentin also works on the GABA receptor. It's an anti-seizure medication. They also use it for neuropathic pain. And a lot of people I know for mild to moderate withdrawal consider it a very good medication, will regularly use it. And so gabapentin's a tool, the diazepam stuff's a tool. Some places will use barbiturates like phenobarbital, which we won't talk about today, but it's also a very, very good drug if the person's having really, really bad withdrawal symptoms and such. And for this detoxification phase, the biggest part is just really getting that buy-in about when and how to do it. And for me, I find I need to be seeing the person like weekly to really get that plan going and get it started, right?
Family doctors giving any of these meds?
They can. It's not part of common practice.
No.
And
so you're not a typical family doctor isn't prescribing gabapentin generally.
Not for alcohol use disorder, but I think it's changing a little bit. The Valium and stuff, or diazepam, they sometimes would, but you don't want to get in that messy situation where you're giving Valium and they're drinking,
and you don't know if they've stopped,
so
and
forth.
There's no follow up.
Yeah, and historically, in terms of what family doctors would treat, alcohol use disorder historically wasn't always part of it. Right, it would be to send somewhere else, but there's been a lot of education, and some of the newer grads are adding it. But you know, it's tough when you have doctors that are responsible for so many conditions. They're like, oh, just add one more. Oh, just add one more. Just add one more.
Yeah,
it's a lot. So you get them through the detoxification phase, and then the next thing after that is the maintenance piece. And there's a couple of medications, naltrexone or camprosate, that are first line for alcohol use disorder. One of them is better to be on in terms of maintaining abstinence once you've stopped for a few days. The other one helps with cravings and reduces your drinking. So naltrexone safe. I normally drink 6 beers a night. I take the naltrexone 30 minutes before I start drinking. I'll probably have 3 or 4. That'll be enough, but I don't get the same relief that I would. There is some evidence for topiramate and for disulfide, which used to be called antabuse, but you just always want to be careful about that one, just because when you drink all the antabuse, you get really, really sick, and the last thing you want to do is give that to somebody. They drink, have a heart attack, or whatever that might be. And so there's that, and then there's all these different treatment programs. So there's AA, Alcoholics Anonymous, there's Smart Recovery, there's different treatment programs. There's a lot of government-funded treatment programs, but the wait list is quite long, and for a lot of them, you have to get someone like yourself to do the gain so that they can get into an Ontario, right? So the gain is it's what's it, a 10-hour assessment that you do with a patient?
It doesn't take 10 hours.
No, it doesn't take 10 hours. So
no, it could take between 90 minutes and kind of 3 hours.
Okay, so it's a 3-hour assessment you have to do.
It's very intense
with a lot of closed-ended questions, and once you're finished that, you can submit a referral to these programs that usually take 6 months to get into, a year to get into?
Well, it depends what's happening, but we're generally looking at sort of treatments now 3 to 5 months right now in Ontario. That's what we're looking at for an OHIP funded bed, for a government funded bed. Okay. And then we have pre-treatment places that so they can go to a detox, then from a detox to pre-treatment, and then to the treatment, then to either post-treatment or to safe house, sober living house, not safe house. Beyond that.
That's fantastic. And so you have that. And then the parts that I didn't talk about were what's involved in the assessment, but I think we have a couple of other videos on that. And in the assessment, you just really try to figure out what the impact of the drug is in their life, what does it do for them? You try to think about how to replace with healthy behaviors. And you also try to figure out other significant medical or psychiatric comorbidities. And then for the treatment phase, when you're trying to get buy-in, you think about things like motivational interviewing or motivational enhancement therapy or solution-focused therapy just to get that buy-in. You think about things like cognitive behavior therapy or community reinforcement approach, which we have another video on, really in terms of how do you make your sober life so exciting that you wouldn't want to miss a day by drinking. There's the community reinforcement approach in family training. So say if I'm drinking heavily, but I'm like, screw you, JP, I'm not coming in to see you. And then my mom comes in and I'm like, what do I do? My son, he's drinking.
Yes.
You could use the craft formula to 100%. Help him. And we have a video on that as well. And say hypothetically, I started drinking at 7 or 8 years old. When you hear a story that someone drinks at 7, 8 years old, what do you think they might have been through?
A lot.
A lot, yeah. And so a lot of times you think about trauma, they don't always share that stuff as well, right? And so that's where stuff like the seeking safety, trauma, PTSD treatment may play a role as well. And so it's almost like, for me, and maybe part of it is because we work in alcohol clinics, we work in alcohol and opiate clinics primarily, but they do other stuff too. So somebody comes in, you do your assessment, you try to get buy-in and try to offer them, or at least make sure they're aware of all these options, and then you try to connect them to it as well. And sometimes if you're very, very lucky, you can get them connected to different treatment, different housing, different this, different that, and you can pick up some comorbid psych diagnoses, offer treatment for that too.
Sure. I mean, it's very rare that it's the substance use that's the only problem, right? There's substance use, something typically predated the substance use, right?
Yeah.
Even if you're talking about the 7-year-old's drinking, there's a reason there's a reason why the 7-year-old's drinking.
Yeah, and sometimes it's stuff that's clear. Sometimes it's stuff that we're not sure how to approach it, right? Imagine somebody has a traumatic brain injury or acute brain injury, and then they don't have the executive functioning to plan or do these things, or they've just been living such a life of depravity, over the last 10 years. How do you pick yourself up from that, right? It's a long process.
It's a long process. All right.
Is that good for today?
I think that's good for today.
That's good for today.
All right.
So should we summarize what we talked about?
Let's do it.
So we got together today to talk about alcohol use disorder. We talked about in the news how they talked about these new guidelines, but really what it is just accurate risk from the CCSA organization. And then we talked a bit about alcohol use, right? So how do you screen for it? What are the different phases of treatment, like detoxification, the maintenance phase, the referral to different programs? And then we also talked a bit about some of those comorbidities and how it relates to other talks that we've had as well. We talked a little bit about the medications, but we didn't go into depth of it. But you know what? It's okay, because those that want to learn more, we'll share links of comprehensive guides by real scientists.
Yes, absolutely.
And they're designed as in depth, but also as handouts and stuff like that. And we hope that all of you, if you're wondering about your own drinking or you want help with a family member who drinks, you have some idea of what the treatment might look like moving forward.
100%.
Okay.
Sounds
thank
good.
you.
Thank
Great.
you.